Type 1 site, another one, the lateral incisor, and we'll see how we progress with this. Again, virtual treatment planning, keeping the implant placement towards the palatal aspect of the extraction socket. Utilize that triangle of bone concept towards the palatal bone that Scott Gans first described in the 1990s. And from that, similar to the previous case, we're going to place our implant in a relatively thin ridge. The good thing, though, if we place it, as you see here, we're actually able to maintain a distance of bone of about 2 millimeters, and that becomes critical also. So we're treatment planning that into our case, placing the labial part of the implant to allow us to maintain a distance from the labial aspect of the implant to the outside of the labial plate of at least a minimum of 2 millimeters. This then is transferred to the mouth, atraumatic extraction, graft the labial aspect of the extraction socket as you've seen earlier. Place, in this case, an ankylose CX implant. It's an indexed implant with a platform switching. So talking about implant design, we want an implant that gives us very good primary stability, an implant that is kind to the interface within that 2-3 millimeters of the crest of bone, so you want progressive threads that don't stress the labial plate, and then a connection, preferably very rigid platform switching that allows us to protect that labial plate. We do subcrestal placement and stay away from that labial plate. You can see, we can also take our final impression at that time. And looking at this relationship, this is one that allows us to really create an environment for soft tissue that's absolutely excellent in terms of soft tissue health. You can see that here we are at 8 weeks. And we've removed the temporary abutment, and we can really look into that zone. We have very thick tissue, as you can see on the labial, that we've been able to maintain, and very healthy environment, very, very healthy soft tissue environment inside that sulcus, which becomes really a very critical component to maintaining tissue health. We have an indexed abutment previously, and we have a Morse taper connection, which is bacterial seal, is excellent, and at the same time the stability creates a very rigid stability. Previous to this, previous to the CX, we didn't have an index, so only relied on a stent or a guide to put us in. Today with the CX, we don't need that, but we still have the other advantages of the Morse taper for an excellent stability. And as we progress with this case, you can see that at 8 weeks, we're able to now put in our final abutment, create an environment where all the aspects of design and interface development are really in play. If we look at this, we have an environment where we have a good load-bearing crestal component of the implant. The microgeometry of the implant, the roughened microgeometry, extends all the way up to the interface between the implant and the abutment. Previously, it used to have a polished collar, and that's very critical. And then having an abutment, as you see here, that actually built into it is, besides the platform switching, that creates distance from the connection of the implant to the restorative abutment, which is further away from the labial plate. We also have a built-in straight to concave emergence profile that allows us to have a much thicker tissue in that critical zone where color becomes very, very important, as you see here on the right part of your screen. So a lot of the things that we're looking at today, no matter what implant system you may want to utilize, we're looking at emergence profile. It becomes very, very critical. We're looking to create environments for thicker tissue, and we can do that with a lot of what we're seeing here. Long-term color stability, much more apt to be able to do that when you have stable labial plate, thick tissue to be able to do it. Bacteria-proof connection. So those are the things that we're looking for in implant designs and connection. Micro roughness to the interface. And you can see when we utilize the system and incorporates the one abutment, one time concept, it really starts to really display all the aspects that we're looking for. And you can see that displayed in this video. A type 1 site, thick tissue. We want to keep it simple. We're going to place our implant, in this case an ankylose implant. We're going to be able to also, having utilized our virtual planning, place it excellent relationship to the adjacent dentition, and also have an abutment chosen. In this case, a balanced ceramic abutment will be utilized. It's anatomically shaped with an excellent margin incorporated in it, and it actually is able to be delivered immediately with very, very minimal changes or preparation by the ceramist or by the restorative dentist. Is the implant in place? We take a pre-machined or pre-contoured, I should say, contoured abutment, balanced abutment, and put it right into place. You can see how it follows the gingival margin. This is before seating. And then after seating, the margin is just below, the preparation margin just below the gingival margin, so you don't have a lot of depth. You don't have to worry about cementing in a much deeper environment. It follows the scallop of the soft tissue in an excellent manner. When we see how this is actually displayed clinically, you can see how immediately afterwards we're able to have a situation where the abutment with very minimal preparation, because of the design, because of the incorporated straight and concave emergence profile, really allows for thicker tissue in that area. And we can then tissue sculpt this area with a temporary, this is a temporary restoration that we can sculpt. As you see here, these become very critical because we can use that extra distance between the abutment and the tissue to really use contour to manipulate the emergence of the tissue. Here's the ankylose system, balanced abutment, anatomical abutment in place. Emergence profile, flat to concave, allows for much thicker distance. Then we use a ceramic abutment to then build up the case. Again, notice our goals, which is maintaining the thickness of the tissue, developing the area optimally, and following the contours that will eventually be part of the restoration. All of this can be treatment planned virtually and delivered in a very efficient manner. Critical to all this, really, in the end, is the interface. Integrity and the position of the soft tissue. The labial margin, the color of that soft tissue over a long period of time is dictated by the stability of the bone and the soft tissue interface between the implant and the abutment. So those are the critical factors that we look at. If you look at this, this is at the time of implant placement. We had grafted above the implant, and this is what you're seeing here. Literally, the grafted bone is above the shoulder of the implant. And over a period of time, we've been following these cases, but these are the interfaces. What kind of implant design do you want? What kind of abutment design we're looking for? And this really comes close to giving us what we want, no matter what, again, no matter what system you're looking for, you're really looking for these very critical aspects of treatment. On the right part of your screen, this is what it looked like 6 years later. You've lost a little bit of that grafted bone that's remodeled, as you see with the green arrow here. And if we look at it here, but it's still above the shoulder of the implant 6 years later. And this follows this histology from Dr. George Romanos, that literally on this type of implant, you can get bone above the shoulder, creates a much more durable environment to sustain soft tissue health as well as color in this area. What's the future looking at? Many are looking at, this is a paper by Professor Wang that was published in Clinical Oral Implant Research in 2008. And this is very exciting for me in particular, because if we can now look at surfaces that are now are going to be put on the abutment itself, not just on the implant. So with the implants taking the roughened surface above the shoulder, yes, we're getting bone above the shoulder, as you can see on the left part of this histology. But if we are actually able to take a roughened surface or a tissue or bone kind surface onto the abutment itself, and the connection is rigid, we should be able to get, as this specimen shows, even bone integration onto the restorative abutment, at least for a certain distance, maybe half a millimeter or a millimeter, which will even create more stability. And we can follow this with similar parameters today with cone beam CT scans. As you see here, this is an X-ray from Barry Goldenberg showing us the stability of the labial plate. So a lot of these interfaces, our ability to measure not only histologically in an animal model, but also clinically over a period of time, is really where the state of the art is going. No longer about just a general kind of implant site development. We're looking at interface development. We're looking at developing the area, especially as the implant and the labial plate and the emergence profile. And over the coming year, there's going to be many seminars, webinars, and there's a lot of content already on the site that looks at these different interfaces. Interfaces of bone, the bone between a graft and the underlying recipient cell, or the bone between the implant and the bone itself. We're going to look very critically, as I've tried to do today, between the connection and the interface between the implant and the restorative abutment. And of course, the interface as the emergence profile comes into the mouth around the gingival margin. All of these are very critical. We've really quite a lot to discuss, and we will do so again. I will try to share more webinars with you in the future. But as we look at that, to conclude today's time together, we're looking at thread design for optimal primary stability and crestal stress distribution. I think that's very important to look at the implant design. Platform switching, I think the science is more and more showing us that that does have an influence in terms of bone stability. A rigid connection, very, very important. Subcrestal implant placement to factor in some of the grafting that we do within the extraction socket in particular. Taking the micro geometry and micro roughness up to the interface with the abutment, and maybe in the future even onto the abutment itself, into that first millimeter or so above the implant. Concave emergence profile, and at least 2 millimeters of hard tissue thickness and soft tissue thickness on the labial of our implants in the aesthetic zone, based on the work that I cited of Uli Grunder for bone and Ronald Jung for soft tissue thickness.